Ever wonder how Acrosoft IQ Panoptics and Vivity fit together into your practice? Meet Candace and Kathy, twins who both need cataract surgery. Click the link to see how their doctor chose the right IOL for them.
Hi, everyone. Welcome to episode 4, season 2 of our episodes in Rising Stars in Ophthalmology. I'm here speaking to you tonight as the co-moderator, along with Dr. Ashman Argawal, who will be joining us shortly. But I wanted to get tonight's show started and thank you everyone for listening, and to thank all of our celebrity panelists and our rising star, Dr. Alanna Nattis, for being here. First, before we get started, though, I'd like to thank our sponsors for the whole entire season. And we really appreciate our sponsors of Allergan, Alcon, Visus, Avellino, Dompe, Sun Ophthalmics, and Tarsus. And I'd especially like to thank Visus tonight, as they are sponsoring this specific episode. Representing Visus tonight will be Dr. Sam Garg, who will say a few words first.
Thank you. Can you see my screen?
Yes.
Okay, excellent. So on behalf of Visus, I'd like to talk a little bit about the patient perspective, how presbyopia impacts quality of life. So when we look at patients, and as you get older, many of you on the line probably aren't experiencing this yet, but for those who are, they know that near loss of vision can really be a big issue when it comes to aging, along with hearing loss, arthritis, high blood pressure, high cholesterol, and dry eyes. When patients, are asked about their reading glasses, they're really inconvenient and they negatively impact self-esteem. And it doesn't seem like that big a deal, but once you actually have to start using them, it really is a big deal. And so patients have issues when they forget to bring them, when they need them in certain situations, such as being in a restaurant or at a business meeting, making them feel less confident, making people feel old, and certainly less attractive. Patients responded positively with the idea of a presbyopia correcting drop, something that would give them more freedom and youthfulness and self-confidence. Some quotes that were attributed to patients include, "It would make me feel more attractive, improving my self-image. It would also offer me the freedom to enjoy myself without limitations, being able to feel young again, not needing reading glasses, freedom from glasses that are often scratched, smudged, and bent. It would be nice not to carry glasses and not to look old in doing so." So all these things sort of reiterate the sort of psychosocial part of aging, especially when it comes to losing your near vision. Certainly there's lots of players in this arena, and Visus's compound is a combination product of carbachol and brimonidine, and so with these two ingredients, they have a very potent cholinergic for pupil constriction, which is important for giving patients, this modulating their pupil size to get a range of vision. And then brimonidine also helps prevent pupil dilation, inhibits contraction of the ciliary muscle, and also increases the bioavailability of carbachol and also prevents redness. So currently they're in phase 2 and they're expecting a top line data readout expected in Q4 of 2021 with their development timeline shown here. Q4 of 2021, pivotal trials commence. Q4 of 2022, readout of those pivotal trials, and with an NDA filing in Q4 of 2022. And with this, I'll turn it back to the program. Thank you.
Thank you so much, Sam. Really appreciate it. And thank you again to our sponsors and to Visis. So now I would like to share my screen and let's see here. I practiced this already, so we should be good. And officially welcome again our celebrity panelists and our rising star for tonight's episode 4 in season 2. And tonight we're going to be speaking about the medical and surgical options for treating presbyopia. So, and as you can see, our rising star is Dr. Alanna Nattis, and I'll be introducing Dr. Farid, Dr. Hill, and Dr. Nijm. All right, so to begin, we have Dr. Marjan Farid, and she attended college at UCLA. She's a California girl. She also did med school at University of California, San Diego. She did residency and fellowship at UC Irvine. Her current position is a clinical professor of ophthalmology at UC Irvine. And also she's the director of cornea, cataract, and refractive surgery, and also heads the ocular surface disease program at UC Irvine. And on top of all of that, she's the vice chair of ophthalmic faculty. So she has an amazing CV. What's also interesting is Dr. Farid was also a rising star in the past for OWL Awards. In 2016, she won the Rising Star OWL Awards. So this is a territory she's very familiar with, and we're honored to have her here tonight as one of our panelists. So thank you very much. All right, next up we have Dr. Warren Hill. He attended college at the University of Maryland and did a double major in marine zoology and studio art. He did medical school at University of Arizona, ophthalmology residency at the University of Rochester, and he's in private practice in the East Valley Ophthalmology practice in Mesa, Arizona. And a very interesting hobby of his is flying military airplanes for air shows. In addition, we all know Dr. Hill as being one of the fathers of modern biometry calculations, and we can't thank him enough for all of his contributions to our field. Last but not least is Dr. Lisa Nijm, who has she graduated from university at the Benedictine University. She did a combined MD-JD training in Southern Illinois University in 6 years, so that's amazing. She finished residency at University of Illinois and did fellowship at UC Davis. And she currently is in practice where she's the founder of Warrenville Eye Care and LASIK. She's also a CEO, the CEO for Women in Ophthalmology, and is the founder of Real World in Ophthalmology, which many of you attended and participated in just recently. So great. And now we'll move on to our rising star tonight, Dr. Alanna Nattis. She did college at Lehigh University, medical school at New York College, residency in the New York Medical College, and a cornea fellowship at Ophthalmic Consultants of Long Island. Some other fun facts about her: she currently practices at Site MD, where she's a cornea, cataract, and refractive surgeon. She's also the director of cornea transplantation at Good Samaritan Hospital and the director of clinical research in her practice. She's also a clinical associate professor in ophthalmology and surgery. Some amazing photos here that Dr. Nattis has shared with us. And I usually like to give the rising star a few moments to speak about these photos, if you don't mind.
Thank you. And thank you so much for having me tonight. So this is actually a nice timeline. From the first photo on the left, those were my two fellowship mentors, Dr. Donenfeld, Dr. Perry. And then moving all the way to the right is a photo both in the OR of me with my dad all the way on the right and me with my husband, Eric, in the middle. So it's been a true privilege to have such amazing mentors and people I love by my side that I get to work with on really a daily basis.
Great. All right, a couple more photos here. All right. Can you see these photos too, or is there a little lag?
Yeah.
Okay, cool.
I'm suspicious that Eric might have sent these over. These are just pictures of us one was at a good friend's wedding, and then my family has a boat. It's a big part of our summer activities. So that was on the boat a long time ago in that bottom picture.
I think he just wanted to be part of the presentation.
Yeah.
He didn't want to be left out. Okay, good. And also, obviously we know you're expecting a baby very soon. So we're all very, very excited and happy for you, and honored that, 17 days before your due date, you're willing to sit down with us and share your pearls, because I know it's a lot going on and a lot to add to your plate. So thank you again.
Oh, thank you.
Of course. So your turn to take over. I'll stop sharing my screen here. I think, hold on. Maybe they can kick me off. Hold on. The technical part's always the hardest for me. Okay, there we go. So now you can share your screen.
Okay. All right. So hopefully you all can see this now.
Yes.
Okay. So again, my name is Alanna Nattis. Thank you so much for having me here. We're going to be discussing the medical and surgical options for treating presbyopia. These are my financial disclosures. So what we know about presbyopia is that it's a big problem, and we're fairly good at treating it, but we need to do better. It has a huge prevalence, 1.8 billion presbyopes in the world. Over 800 million people are visually impaired, as Dr. Garg was saying in his presentation earlier. And our current technologies focus more on lens-based technologies to help treat it. Age and certain patient factors also determine how we treat presbyopia. So moving forward, we have to meet the need with either IOL technology. We do have some very exciting pharmaceuticals that are becoming available. And we really are going to, I think, start considering presbyopia as less of a nuisance and more of a clinical condition that we can treat on multiple facets. So these are some of our awesome presbyopia correcting IOLs, which I think most of us are familiar with in terms of treating presbyopia. From accommodating technology to older bifocal IOLs, EDOF, trifocal technology. And so I just had a question for Dr. Farid. Are there any future IOLs that you're most excited for?
Thank you, Alanna. Absolutely. So I think the ones that are available now are fantastic. We have our trifocals and our non-diffractive EDOF, which have really become a staple for my cataract refractive patients, but also a couple of really nice ones that we're looking forward to seeing become available. One is the IC8, the pinhole optic, which I think will be exciting for patients who have irregular corneas and may not be a good candidate for some of these more diffractive ways of extending depth of focus. So that's exciting. The other one is a truly accommodating lens is sort of the pinnacle, I think, of what we've been striving for. And I know LensGen has one that is in trials, and so we'll see how that pans out. But a lot of exciting technology in the pipeline.
Yeah, I agree. So like you were saying, the LensGen IOL seems like it's going to be very promising in terms of accommodation. The IC8, I think, was going to be great in terms of not only providing an increased depth of focus for normal patients or patients with irregular corneas, but also perhaps those with irregular corneas, and some other options that just may allow us to change technologies as we move forward, such as the IOLs and the implants for Omega Ophthalmics and SC9. So going forward, so we're going to just go over, these are some cases I actually had from my own patients. This is the first case. She's a 60-year-old female with myopia. She has relatively thin corneas, 450, 460 microns, and she has a contact lens wearer. She came in and she was asking if she could somehow reduce her need for glasses. She usually wears contacts for distance. She could not really tolerate multifocal contact lenses. She wears her readers for near. And with a minus 475 sphero use, she's 20/20. She has no evidence of dry eye. So Dr. Nijm, I was just wondering how you would handle this patient.
You would think I would learn to unmute by now. Thanks so much. This is a great case to start with because this is something that I think we all see in our clinics. She's a 60-year-old with moderate myopia. She corrects well. She's got those topographies that are really suspicious for keratoconus, given the inferior steepening there. But she corrects pretty well, and she doesn't have any astigmatism, at least it doesn't look like on her refraction, and maybe just minimal on her topography. So, I would, she wants to decrease her, I would want to know what her higher order aberrations are and see if there was any possibilities of doing an extended depth of focus. Otherwise, I would consider a monovision. If she's thinking about that, always keeping in mind the myopes, although you said that she's contact lens wearer that's got glasses for near. So she's not one of those that's lifting her glasses up to read. But my low or moderate myopes, I'm always cautious with that conversation to make sure that they understand that that will be gone if we correct both for distance.
Yeah, those are great pearls. And I think those are all very important things. I agree. I didn't love her topography. So the option of like corneal-based surgery, such as LASIK, was really not in the question for me. So, we discussed that, but I just thought that she was high risk given the topography and her corneal thickness. We talked about a refractive lens exchange, but she wasn't quite ready for intraocular surgery. And so she decided that she just was going to stick with her contact lenses. And we talked about some future pharmacologic technologies that might help her. So one thing that we have that in the US that we do, depending on how much monovision you do, either a little or a lot. Monovision can be great for patients who have been using contact lenses that are for a long time in a monovision fashion for LASIK, but it's not for everyone. It can be used in both phakic and pseudophakic patients. And outside the US, there is some use of this Presby LASIK. And there's two different ways of doing it, where you can treat the central cornea to create more of like a hyperopic ablation, or the peripheral cornea where you're creating more of a myopic ablation. The limitations with this is that, one, it does create a multifocal cornea. So many years down the line, if the patient needs cataract surgery, hard to predict the IOL calculations. And also you are treating presbyopia, which is kind of a moving target. It does get worse over time. So while they may get a year or a couple of years of really great range of vision with Presby LASIK, it may not be the best answer. And that might be also a reason why it hasn't really picked up much in the US. But it is something that has come up. Patients have come in asking about this for presbyopia-based LASIK. Another thing that's in development that's kind of interesting is scleral modifications. And this is based on the idea of cross-linking. So when we think of cross-linking, we generally think of the cornea and we think of keratoconus. But as we know, as we increase in age, there's increased cross-linkage in the ocular tissue. So that means the sclera, and that increases the rigidity of the ocular tissues, and it also decreases the accommodative reserve. So there are two specific scleral modification therapies that are being investigated to help increase accommodation. And these are generally geared towards patients who are early presbyopic emmetropes with less than a diopter of astigmatism and don't have cataracts. The first procedure is called laser scleral microporation, and it makes this matrix of micropores in the four quadrants of the sclera. And essentially, it uncross-links the rigid scleral microfibrils and improves compliance of the tissue and improves accommodation. And patients who have had this done in studies can gain 2 to 3 lines of distance-corrected intermediate vision, as well as 3 to 4 lines of distance-corrected near vision. Right now, there are studies going on outside the US, but hopefully in the US within the next year or so, we'll have some studies going on here. It seems fairly interesting, especially since you're not working on the visual axis. Another option that's scleral based is this visibility micro insert. So also working in 4 quadrants around the sclera. It's inserted and attached to the scleral wall to enhance any residual accommodation. Relatively quick surgery based on the studies, and the patients tend to have relatively good results. Again, you're not working on the visual axis. So hopefully in the future, if these patients need cataract surgery, it shouldn't affect IOL calculations and things like that. But I think we'll have to see more results going forward. So moving forward, we have our second case. So this was a 57-year-old male. He had a history of myopic LASIK, and he also had visually significant cataracts when he came in. So his goal was he wanted to have reduced need for glasses post-operatively, and he wanted to understand the IOL options that were available to him. So we see his topography. He has mild myopia for his prescription, and he has 2+ nuclear sclerotic cataracts on exam. So knowing what we know about his history, retinal exam is normal. Dr. Hill, what IOL options would you consider for this patient?
Well, the first thing I would do is I'd look at his aberration profile, because these patients, they often have a lot of spherical aberration, especially if they had a large myopic ablation. But if the ablation is in any way decentered, they're going to have coma. And as we all know, coma is a form of irregular astigmatism, and it can be a killer of multifocal lenses. So I'd like to see his aberration profile. And oftentimes, when you look at the axial curvature map and then you look at a 6 millimeter aberration profile, which is what we use as the standard, so that we're all talking about apples and apples, we get some surprises. And back to the topic of aberration profiles, remember, aberrations don't exist individually, they exist as a group. And one number that's thrown around a lot is 0.3 microns of horizontal or vertical coma might be a game killer for a diffractive optics lens, but it really depends on what other aberrations are present, especially spherical aberration. So let's say you have maybe 0.25 microns of vertical coma, but you have a lot of spherical aberration, as we often see with myopic LASIK. That person may not do very well with a diffractive multifocal lens. So first order of business is, what is the aberration profile? And then we kind of go from there. Often when these people have this kind of a problem where they have a lot of aberrations, we'll offer them a cautious monovision. We won't go for hard monovision like -2 or -2.25, 2.5, because oftentimes they'll end up with -3 or -4. We get these big overcorrections occasionally. So there are a couple of things that I offer people. One is we target mild myopia because we don't want to have a hyperopic surprise. And then we talk about a spectacle correction in the form of a progressive. And one nice thing, no one ever talks about that, but a progressive lens, like everywhere I look, everything's in focus. And so I know that the idea is to decrease his dependence on glasses, but if we're going to give this patient absolute presbyopia with an intraocular lens, we have to have some other way for them to function. So do we have an aberration profile on this patient to start out with?
I don't have one for the presentation, but we did have one done. And it was not something I would have performed a diffractive IOL surgery, based IOL surgery on.
You show remarkable restraint. That's very good. Yeah, because let me just share, not to go on and on here, but one other thing, my partner Yuri McKee and I, we see a lot of unhappy patients from other practices. And when people come in with a multifocal lens and they've had prior refractive surgery, the very first place we go is an aberration profile. And a lot of people, they just put the lens in and hope for the best, and then they have to sort it out afterwards. So I just can't overstate it enough. The aberration profile is really one of the very first places you look.
Actually, can I just make a quick comment? Even
Sure,
with this topo, you can appreciate there's a little off-center treatment, or it appears so, at least in the left eye more so than the right. So that should, at a minimal, send up raise up a red flag.
Oh, absolutely. This person's going to have horizontal coma, no question about it. But the thing is, you never really can tell until you actually do an aberration profile. And sometimes where people can get in trouble is they may use something like the eye trace, which may have a 3 or 4 millimeter pupil, and the numbers will be low. Remember, aberrations are radius dependent values. So that's why we always use a 6 millimeter aperture for the reference. So we know kind of, where things stand, even though the patient may be elderly and not have a 6 millimeter pupil. So I think the take home lesson here is, what's the aberration profile? And then, show restraint and know that we can't offer everything that's in the toolbox.
I think also, I think also you're going to have, this is a little bit of what we were alluding to earlier, because you see it's a -150 and a -1. So I would want to know what kind of presbyopia, what are they doing right now? And to Dr. Hill's point earlier, when you correct them, are you going to correct them to a point that they're still happy with that? Because, we have to balance, oftentimes people have had LASIK, want that same, they're thinking they're going to come get cataract surgery and get that same great results that they got after LASIK. And so I think it's important to balance those expectations with understanding what they're doing right now for presbyopia and what you would end up after a cataract surgery.
And what I tell patients is that LASIK prior to cataract surgery is really one of the most accurate refractive procedures that we have, especially with modern generation LASIK. But cataract surgery after LASIK is the least accurate refractive procedure that we have. And it's a little bit of a paradox, isn't it?
I think that's a great way to put it.
Yeah, I think that's all wonderful advice. And actually, this patient had seen 2 other cataract surgeons before coming over to our office, and no one had explained that to them, that, the fact that he had LASIK and now has cataracts, it poses a little bit of a problem, especially looking at the topography that he has here and also his aberrations. So, of course, we went over the options for him, monovision versus monofocal IOLs, even a light adjustable IOL if we wanted to touch up the refraction afterwards. We did talk about EDOF and diffractive IOLs, and as well as future technologies. But he ended up going the conservative route and just had monofocal IOLs and ended up being quite happy with progressives in the end, actually. So that worked out.
Yeah. And actually, this is what I do for airline pilots. I see a large amount of the aviation population here in the southwestern United States. And, remember, if a working airline pilot misses one letter on the 2020 line, he's not working. So we do monofocal IOLs with a high quality adaptive progressive. And as I mentioned, everywhere you look, everything's in focus. It's really hard for an IOL to compete with something like that. So it's an option we often don't talk about.
Absolutely. Yeah, no, our pilots are very important. So we definitely want them to be seeing as clear as possible.
Especially these days, if you can get a flight, right?
Yeah. And I think I think your last point on there is something that this is where the change in paradigm is going to be, because we now have drops approved for presbyopia, that this may be even a more reliable option for some patients. Obviously, we'll have to see how it works in that population, but this is presumably a younger patient who probably still has a lot of accommodation or a fair amount of accommodation in comparison. And most probably will do pretty well with presbyopia drops. So that will offer quite a bit of range of options for them to choose from.
Yeah,
I'm really looking forward to the IC8. Right now, I'm referring patients to Germany, to Dr. Dick, who's doing those surgeries. But the IC8, for a lot of very unhappy patients with, aberration profiles from the Klingon home planet, after LASIK, the IC8 may actually give us some relief, and it would be very nice. And my friends in Europe who put it in, they're raving about the results.
Just for some discussion, I think there was also what we started doing in India was something called as pinhole pupilloplasty, basically in the really bad ones. I mean, I'm not talking about, the very, very subtle ones, but the really bad ones, irregular, very high astigmatism, which definitely you cannot correct with any other mechanism. You started to close the pupil size to about 1.5 to 2 millimeters in the size of the pupil. Even though it's being a permanent closure, the advantages to the patient is immense. And the first day they come and read the last line, which they've not done for 10 years plus. These are those post-penetrating keratoplasties, post-bad corneas, keratoconus, and so it's been a revolutionary change in treating these patients when you just bring the pupil size down intentionally and fix it at that too. So dilating pupil is not so pleasant for these guys. That's the basic take home. And that's what IC8 is doing with the intraocular lens. Probably is what we'll have to understand when the IC8 comes out in a big way.
Absolutely. That pinhole effect is really important for a lot of patients. So we have one more case here, and then we're going to just move on to some other new therapies. So this is a patient with a history of LASIK 18 years ago, and it's pretty easygoing. He just wanted to come in and say, I wanted to sharpen things up. Things just, I can see, I can get around, I can drive, but it's just not as sharp as my eyes were 18 years ago when I had LASIK surgery. So uncorrected, his vision is pretty good. And with a small prescription, he sees 20/20 and reads fairly well. He has just trace nuclear sclerosis in both eyes. His topography is not horrible by any means. So Dr. Farid, what would you consider for this patient? Would you be aggressive? Would you just be more conservative, tell him to wait?
Yeah, so this is a patient not too unlike myself, who is becoming basically presbyopic, has been used to having really good vision post LASIK, and is now starting to see the effects of, early presbyopia, and maybe a little hyperopic in the right eye. But I think this is a perfect patient for presbyopic drops. Now that they're available, I think not only in the emmetropic eye will the near vision improve, but I think even in the slightly hyperopic eye, you may actually see an improvement in the distance vision as well. Certainly one of the main goals for all of these presbyopia drops coming out is to make sure that they didn't sacrifice distance vision. And so far the data on all of the ones, the one that's available, as well as the two that are sort of right behind the Allergan product that just became FDA approved, they are all showing, really good promise for improving functional near vision.
Yeah, I agree. I think that this patient, especially since he was kind of comfortable, he was just wondering what options were available. We didn't pursue anything surgical for him, but we did discuss that there was some eye drops coming out in the future, so he may benefit from them. So just moving on to the newer pharmacologic therapies for presbyopia, these eye drops, I think, are going to be a game changer for patients. And as you mentioned, Allergan's product was just approved. It's pilocarpine 1.25%. And the primary mechanism of action is really creating a pinhole effect. So it increases the depth of focus without compromising distance vision. And some of them can also activate the ciliary body for some accommodative effect as well. And the nice thing is that the drops really are relatively low risk. They're easy for patients to try. If they don't like it, they just stop using the drops. In the future, there may be some lens modifying eye drops, but those are still very early on in studies that may modify the proteins of the lens and allow for actually some cataracts to clear up, but also to help with presbyopia. But looking at the pupil modifying drops, which are really the ones that are coming to the forefront now, we have Vuity, which was just approved. And it showed in the trials visual gains for up to 6 hours of 3+ lines of near. And it was just used 1 time a day, which is incredibly convenient for patients. There's also other drops that are coming out from Microline, which is also pilocarpine based. It has a specialized dispenser so that the drops are not wasted on the ocular surface or run down the patient's cheek. It might be easier for some patients to use that drop. There's also another eye drop from Presby Drops, which is also pilocarpine based. For BID use, it also resulted in a 3-line improvement in near vision. And then there's some combination eye drops. Nixol is a combination of pilocarpine and phentolamine. And there's a very long durability of effects of longer than 24 hours. So that might be very convenient for patients too. Some compounded eye drops from iFocus, Liquid Vision, and of course, Brimacol, which Dr. Garg had mentioned is Vicis's eye drop, which can create a pinhole effect. And also it does increase the bioavailability of carbachol to also act as a cholinergic agent. So these are some very exciting eye drops. One are on the market and many coming to the market hopefully soon. So Dr. Nijm, how excited are you for these eye drops?
I am super excited for these eye drops. This is something that I think is, it's just such an underappreciated condition that our patients have tolerated for a long time with limited options. And for me, I think this opens up a huge window to treat patients, to help patients. I mean, I've watched even my mom, who, God bless her, has had great vision all her life. And then when she became presbyopic, she must spend, I can't even tell you how many times a day I see her like trying to find her glasses or look at where she left her favorite pair in the car. Or, I mean, I feel like this is not just, this whole class of medications is not just something that's going to help improve convenience, improve vision, but I feel this is going to help improve the lifestyle of patients. And so I'm very excited to have Vuity first come out, and as well as all of these, incredible innovations follow to be able to help our patients treat a condition that I feel has really can have an impact on their day-to-day life.
Yeah, no, I'm really excited too. I think it's just going to be great for both our phakic and I think probably the pseudophakic patients. We'll have to do some studies, but I think it'll be great. So moving on, we have another patient here. So this was one of my favorite patients. So he was a 47-year-old man. He was a postal worker. He had a history of myopic LASIK in both eyes, and unfortunately had retinal detachment, macula on retinal detachment in the right eye, which was repaired. He had a vitrectomy. After that, of course, he developed a cataract in the right eye. So he came in and he said, I want to take care of the cataract and I do not want to wear glasses for anything. His vision was pretty good, uncorrected in the left eye, reading not so bad also in the left eye. But he did have a 3+ NS cataract in the right eye. And he had a trace ERM. So given his history, of having the retinal detachment. His eye was actually in fairly good shape, but we do have his topography here. And so the question here is for Dr. Hill, what IOL options would you consider for this patient's right eye?
Well, you said the
So-
magic
so
word.
glad that went that way.
If he has an epiretinal membrane, he's not going to be a candidate for a diffractive multifocal lens. And it
Right.
might be early, but these things have a tendency to progress and contract. So, that may be a poor choice for him. Doesn't want to wear glasses for anything. Oh, gee, I've never heard that before. The problem is that, God didn't always give us a perfect eye, and especially if ophthalmologists intervene and did LASIK in between. So, monovision is, of course, an option. And the -4 is not something natural. I assume he had a scleral buckle and probably has maybe has some lens-induced myopia as well. So again, I'd want to see his aberration profile. His axial map actually looks pretty darn good. His Ks aren't really flat. As far as I can tell, they're in the high 30s, low 40s.
Mm-hmm.
I'm thinking we might have to just read this guy the riot act and say, you know what, you don't have all the options we wish that we could do for you, and we may be able to give you monovision so you could see at an intermediate distance and perhaps at distance, but to have everything may not be possible. The other thing to remember is that one thing I emphasize when I talk with these people, and we see a lot of these patients every single day, is that this isn't about not having to wear glasses. That got taken away from us when you had LASIK. We can't really measure the cornea with accuracy, and the formulas don't work. So we're going to do our best to get it as close as technology allows us, but you may still have to wear glasses, and that's something you're going to have to accept. So it's kind of like that little girl in the Willy Wonka movie, who wants the squirrel. You just can't have that because of what happened, because you've had LASIK. Once you've had LASIK, some things have been taken away. And kind of when you get something, you give something up. And what people give up when they've had LASIK is they purchase the decrease in myopia in the currency of contrast sensitivity. And so we just don't have all these options. So I'm delighted to say a few things and then find out exactly what it is you did for this person and what he was willing to accept.
Can I make a quick comment on this one? Dr. Hill, would you consider, because I think for me, with proper patient expectation and education and so on, I completely agree. I would avoid a diffractive optic, but what about a non-diffractive EDOF?
Like
and there's only one on the market, which is, I think, but you still need to educate patients because, sometimes when they're paying for a lens upgrade, they still expect perfection despite the education of, you have an epiretinal membrane, you've had a retinal detachment in this eye, this is all going to limit your vision. But there is this lens that can potentially give you a little bit of functional intermediate, for example.
That is correct. And, the way the Vivity works, most people don't understand how Vivity works. It's a phase shifting lens. And what it does is it preserves contrast across an interval. And it's a relatively small interval, but it does preserve contrast. And theoretically, the Vivity should work better in this kind of situation. My own experience is I haven't really seen that. I don't know what your experience has been with the Vivity, but the eye really has to be pristine for a phase shifting lens to work well. It's not as bad as a diffractive, but I would still be cautious. I would be cautious.
I completely agree. And I'll tell you what my experience is. And in a patient, one of my early trials was, okay, well, with mild ERMs, we can put it in, but the quality of vision wasn't coming out good unless they have a really nice foveal reflex.
Right.
I wouldn't do it. So if it's an ERM that's not distorting that foveal dip, maybe. But if it is at all distorting that foveal dip, or if there's a blunting of the foveal reflex, I completely agree. Based on my early expectation, I still wasn't getting that really good quality of vision that you would get with a monofocal.
Yeah, and I'd be leaning more towards monovision with limited expectations, given the epiretinal membrane, given the reduced contrast from myopic LASIK. And again, it's our job to be the adult in the conversation. Yes, they want that, but, we always can't do that. We have to be the adult, and we have to be the one to tell them as best we can what their options are for long-term happiness, just not immediate gratification.
Can I ask if would you think differently if you're talking about an iHance or even an Invista?
I don't know. iHance, of the panel here, what's been your experience with iHance? Have you been thrilled with the results?
Yeah, for me, I'll tell you, I've been using iHance I've almost switched to that completely for my monofocal patients. I still don't overpromise anything. It's a monofocal lens. Sure. I'm still giving the same conversation, but I tend to get a little icing on the cake if I offset the second eye by a half a diopter. I'm getting patients who are able to see their phone and, or large print on their phone. So I think that's already a step up from, they do lose a little bit of the sharpness in the distance, tiny bit, but it's really subtle. And so
that's what people comment on. They say the distance isn't quite as good. But again, back to monovision. I mean, monovision done correctly is actually a thing of beauty, is it not? I mean, it's really one of our favorite modalities, and you can really do a lot with monovision. There's very little downside. Of course, you're not going to get near vision up close, but it's surprising how well people function, except for small print up close. If you're -1/4 for the distance eye, and maybe -1 or -1.25 for the near eye. Wow, these people actually do very nicely. So what did we put in?
Yeah, I agree. So, so this patient was seen before Vivity came out. And also he had a 27.5 axial length, millimeter axial length eye. So the power would have also been a little too low for what Vivity initially had available for him. We went over everything. I told him he is absolutely not a candidate for a diffractive IOL. I would not implant that for him. And so we talked about just putting in a monofocal, and the fact that he does have a high risk eye. He already had a vitrectomy and a retinal detachment. And unfortunately, it changes sometimes where the effective lens position is in these patients I've seen, especially when they're so myopic. So we ended up talking about putting in a monofocal lens, especially given his job. He has to pop in and out of his truck all day long and see the road clearly. And prior to having LASIK, he used to wear contact lenses, and he didn't know that after having cataract surgery, you could wear a contact lens. So he ended up we did a monofocal IOL, and on the weekends he would wear a multifocal contact lens, and he would really not be so dependent on reading glasses. And he's actually fairly happy, thank goodness, and thank God his retina's doing fine. And but it was a long talk to have him kind of understand that having cataract surgery was not going to turn everything around, unfortunately, for this situation.
I'm delighted to hear you remain the adult in the conversation. That's nice.
It took a lot of strength, but yes.
Yeah, welcome to our world. We see these patients every single day.
Well, I think you handled it beautifully. My other question I was thinking of, this is somebody who's older or whatever. Let's say they had the cataract in the other eye too. Just asking Rising Star and the panel, would you consider putting a monofocal in one eye and then maybe an EDOF in the other eye, depending on before Warren asks me what his higher order aberrations are?
I think as long as the higher order aberration profile is reasonable, I think, I'm hesitant about putting a diffractive multifocal in only one eye, because it does take some neuroadaptation. And if both eyes aren't on the same page, it's harder to get used to. But I think it would be reasonable, again, to put in a non-diffractive EDOF in the good eye, and perhaps also in this eye, again, with a good foveal contour. So, sure. Yeah, I think that's something that can be reasonable. I think that they have to understand it is
sometimes noticeable. I mean, I've had patients who have a non-diffractive EDOF in one eye and a diffractive multifocal lens in the other eye, and they'll do this all day long, which we tell them not to do. But they're like, I can tell the difference. Like, I can see everything's clear. I can read, the distance is great. But when I cover this eye, this one looks different. And when I cover this eye, I can't see that much up close. So especially in this kind of patient who's had LASIK and has some multifocality to his cornea now because of the LASIK, and he has the ERM, and he had a retinal detachment. I really personally, for me, and I tend to be a little bit more on the conservative side, I don't think I would want to introduce another thing for him to be noticing in his vision. I think I would stick to bilateral monofocal lenses here.
I would agree.
Alrighty, so another interesting surgical option, but not really in the US yet, maybe one day, is refractive cross-linking. So this is something that's mainly being studied in Greece and Singapore, but we know that cross-linking is used for keratoconus, and it can be used for myopia control. It doesn't do some corneal flattening in general when you do cross-linking for keratoconus, but there is this photorefractive intrastromal cross-linking where a ring of mid-peripheral corneal tissue is cross-linked, and it basically creates a steepening for near vision in the cornea. Some patients in studies can get anywhere from 1/2 to 2 diopters of basically monovision. They usually do it in one eye. It's an epi-on treatment, so it's not the FDA-approved epi-off treatment that we do in the US, and it's a 26-minute treatment. So it's something that's very interesting. I don't know if it is going to come to the US at some point, but it's something that perhaps we may be able to offer patients. It's certainly not very invasive, but my concern with cross-linking is we sometimes never know how much flattening we're going to get, and it can take a while for it to stabilize. In keratoconus patients, so we're looking at normal patients and we don't really know how they'll respond to cross-linking, but it is an interesting technology that we may seek in the future.
Yeah,
so
what you've done is you've created a two-zone refractive cornea, and doing lens calculations for these eyes later on is going to be a lot of fun.
Right.
It's almost like kind of like what we see with keratoconus sometimes, you don't know what part of the cornea that people are using. And yeah, please don't send them to my practice.
Warren's going to retire before it gets approved.
Yes, please.
This
Thank
kind
you.
of the idea of this was also, slightly right before my time as I sort of moved into residency and fellowship. But some of my predecessors were doing conductive keratoplasty, which is sort of the same thought, right? Steepening the surface, but those wouldn't last very long, and there would be this little shift back, right, back to where they were. So this may have a more long-term stability, but then again, as Dr. Hill says, you're really altering future ability to predict IOL powers. So
that's going to be hard.
Yeah, definitely. A lot of factors that I think would need to be sorted out before moving forward with any other surgery for these patients. So our final case here, this was a lovely 55-year-old patient who she was fairly myopic, -6, -5. She came in contact lens intolerance. The right eye did have a cataract, not a very large one, but she did have a cataract. She did have some mild dry eye and no prior corneal surgery. And she said, I would just like to be out of glasses and contacts. I'm sick of putting contacts in my eyes. I don't like how I look in eyeglasses, and I would like to know what my options are. So, Dr. Farid, what options would you consider for this patient?
So if you had shown me a +6 and a +5, that would have been a slam dunk, because refractive lens exchange works really nicely for those hyperopes. With myopes like this, you have to be a little bit more careful, especially in a young myope, because refractive lens exchange can put you at a little bit higher risk for retinal tears and detachment. So that I would be very cautious about that. With a patient like this, I try to make them wait a little bit until their nuclear sclerosis is a little bit more advanced. She wants to be out of contact lenses. It's hard. I know, because I used to be a myope, and LASIK is also an option, but again, you're going to create worse dry eyes for this patient. So there's really no good slam dunk. You're looking either at aggressively treating dry eyes and possibly considering a LASIK treatment. I think SMILE may be an option. I don't do it myself, but that will create a little bit less of a dry eye. Because it's not a flap, you're creating a pocket, and so there may be that option available for her. And then refractive lens exchange, which again, with caution and with collaboration with a good retinal specialist, is going to do a nice peripheral scan to make sure there's no peripheral degeneration that can put her at long-term risk of earlier like retinal tears and detachment or the formed vitreous. I'd be interested to hear what the other panel would do.
Well, this person's still going to have some amount of accommodation. So if you do something lens-based, especially if it's monofocal, as I mentioned before, you'll give them absolute presbyopia, and they'll hate you and they'll hate your dog. So lens-based.
No, if I do this, I definitely do. As long as she's got good corneas, a diffractive multifocal or an EDOF or something like that, because otherwise why do it?
Yeah, it looks like she may have enough astigmatism that the toric iteration of that might be the way to go as well. So it looks like her steep meridian's vertical and it's about 2 diopters, so she might be happy with the toric version. This might be a reasonable case for something like a symphony, perhaps, toric symphony.
But also make sure, I don't know how long she's been out of her contacts, but I would want to make sure that she was out of it long enough that there aren't changes on the topography and changes on the cornea that could be mistaken for, her actual cornea when it's due to the contact lens. Otherwise, everything that Marjan and Warren said are things I would consider, and I would agree with those approaches.
Yeah, thank you. I agree with all of that as well. And as it turns out, she was saying she was sick of her contact lenses, but she was still wearing them several hours a day and not using any kind of treatment for her dry eye. So we talked a lot about treating the dry eye, put her on both tears and pharmacologic therapy for her dry eye, and lid hygiene as well. And actually her cornea has cleared up relatively quickly. Like within a month, she looked a lot better. And she noticed by herself that even though we told her we were going to take a contact lens holiday, she was still wearing her contact lenses, that she was really happy with her vision with her contact lenses now that her dry eye was treated. And felt that she could go and wait rather than having any kind of surgery done to be out of glasses. So this was, I think, a really important thing for her, because she was just going to like a retail shop for her contact lenses, and she wasn't really being checked for her ocular surface. And they just told her, oh, you've got a little cataract. You should go see if you should have a multifocal lens put in. So she came in with this like idea in her head that she was going to have this done and she was going to be fine and out of glasses, when in reality, she just was using drops like twice a day and she's seeing much better and she didn't need any surgery right away.
Find patients who are -6, -5, etc. are rarely without their contacts. Rarely without their contacts. Even when they tell you they're out of their contacts, you better be darn sure they're out of their contacts, because the difference between seeing with contacts and with glasses for them is so profound that it is a difficult chore for them to be out of contact lenses for a while. So good call on treating her dryness here.
Before we finish up, I'd like to bring up 2 things. Soft contact lenses and rigid contact lenses are completely different animals. And with a rigid contact lens, they need to be out of the lens, and the keratometry and topography needs to be stable. That's when you do biometry, is when things are stable. And let's say they have an RGP lens and it has a lot of, maybe it fits tight or it has a lot of lid interaction. It may take these corneas a while to stabilize. So we can't just do a set number like out for 2 weeks or out for 4 weeks. We just need to show that the cornea is stabilized. That's the first thing. The second is one thing that we started doing several years ago in our practice prior to biometry is we optimize the ocular surface. And I can't tell you what a difference this makes in terms of reproducibility of the keratometry, normalization of the aberration profile. The older the patient gets, probably the more meibomian gland dysfunction they have. And warm compresses, lid scrubs, frequent tears for 2 weeks prior to biometry has made a huge difference for us. And we actually will not do biometry unless the ocular surface has been optimized. So if I could leave you all with any one thought, it's to do that if you want to really up your game as far as lens power calculations go.
I couldn't agree more with that. I think that's a huge aspect that a lot of times it's easy to miss. And actually, though we're not the ones usually taking the biometry, but if you take the time and sit in front of an IOL Master 700, I can see when patients have irregular tear films, because you're going to see when it's measuring the Ks on the cornea, the dots, the circles, or the points that it measures on the cornea are not going to be crisp. They're not going to be even. And so if I'm walking by or I happen to be doing the biometry myself, say, nope, we can't, you're not ready. But just what Dr. Hill was saying, I'd like to see reproducibility and stability before I'm willing to accept those as the accurate biometry measurements.
And personally, I found that the warm compresses really make most of the difference, because you're expressing the lipid-rich contents of the meibomian glands onto the ocular surface. And in terms of stability, that just helps so much. In fact, if we have a patient with significant meibomian gland dysfunction, we may even do a lipoflow treatment to get the ocular surface where it needs to be. So the warm compresses are really critical as far as I'm concerned.
Absolutely. There's been several studies now that show significant changes in K readings and biometry, and eventual IOL power choice can be significantly off. And in this day and age where we're really going for refractive perfection on these IOLs, very little room for error. You really can't mess with a unstable tear film. Rapid tear breakup time with poor lipid layer is the number one cause for that. So absolutely agree. Mm-hmm.
Definitely agree. Thank you all for your pearls on that too. So as far as our conclusions go, so that we have multiple current and emerging treatment options. Surgical, we know, IOLs, maybe some scleral-based therapy, and the topical therapies, I think, are going to be awesome. And like I said, I think game changers for these patients. And the future is bright for presbyopia care. So we won't be squinting like my dog in this photo. And I just wanted to thank all of you for having me here and allowing me to discuss these technologies. It's been an honor, and it's been really awesome just learning about what's up and coming and what we can treat our patients with.
Perfect.
Thank you so much, Alanna.
Thank you.
Great presentation. And thank you to all of our celebrity panelists. Amazing discussion.
Alanna, I must congratulate you. This has been an absolutely stellar of a show. And panelists, I cannot thank you enough for being here to give your tips and pearls and advice. I'm sure I learned so much from each one of your comments. It's unreal. And honestly, for the audience perspective, just to give a recap, all you guys saw was a stellar of a show, which actually explains step by step what we really need to do when we see these premium patients, as well as patients with some abnormalities which we have no clue about. And a lot of them, I know what Dr. Hill is also talking about when he comes and tells us that these patients are a little out of the normal. And what, from a recap perspective, diffractive, refractive IOLs, you heard about EDOFs, you heard about the pinhole effect of intraocular lenses, as well as other effects of pinhole pupilloplasty. You heard about drops that are there, which intraocular lens to use in which type of scenarios, and a lot of the new modalities that are probably coming up, may not come up. We don't know how that works out, but you heard about them in through Alanna's talk today in Rising Stars. And thank you so much to bring so many topics under one banner. So that's really been interesting. And the panelists, I cannot tell you, the tips and pearls were so bang on, spot on. It was extremely useful for all of us. And I'm sure the audience are going to repeat watch this program because there's so many subtle tips that are there inside. And don't mind if you get your email spammed by by a lot of the people who are watching the show. So thank you so much. And I also wanted to thank our sponsors for today. Very, very crucial that this program continues and we put people like Alanna on center stage in the spotlight. Thank you so much. And I wish to see all of you at the Academy. If you guys are coming there, I will see you guys, hopefully, if all flights go out on time.
See you there.
Right. I will see you. Bye-bye, guys. Thank you.
Thank you so much.
Bye-bye.
Bye.
Thank you.
Thank
Thank
you.
you, everyone. Bye.